Hello, I'm Ian Gallen. I'm consultant physician at the Royal Berkshire Hospital in Reading, England. I'm going to share with you 15 years of experience which I've had working with athletes with type 1 diabetes. My aim is to help you with practical advice so as you can manage those patients more effectively in your services. The first thing to say is that exercise is good for people with type 1 diabetes. People who do regular exercise more than 3 times a week who've got type 1 diabetes have better control, less nephropathy, less retinopathy. They can have lower rates of hypoglycemia, but it can be difficult for them to control their diabetes while they're exercising. What I plan to cover is what blood sugar responses are with exercise, the various glucose responses with varying forms of exercise, how to adjust insulin bolus rates and how to advise on carbohydrate ingestion. I am going to talk about hypoglycemia and hypoglycemic unawareness, and I'm going to cover the use of insulin infusion pump therapy. Here are some examples of blood sugar responses during exercise from our service. In the first panel, we see somebody who's tried to control their blood sugar by raising it to more than 30 millimoles, but in spite of that, as you can see, blood sugar falls very rapidly. In the second panel, we see somebody who has a very rapid blood sugar fall from approximately 22 millimoles down to 3.5 millimoles whilst cycling in under an hour. These responses are typical of patients doing endurance exercise, and the change in blood glucose are really very large indeed. In the last panel, there's composite exercise. There's been reasonable blood sugar whilst doing cycling, but later on in the evening during aerobics class, there's a further fall in blood glucose. I'd like to draw your attention to each of these 3 graphs that we see blood sugar falling during exercise, but after exercise, blood sugar tends to rise and remain elevated. There's a third phase, which is not shown in these panels, with increased risk of hypoglycemia at night time. I'm indebted to Mike Riddell from Toronto for sharing this slide with me. This series of graphs describe the various responses we see during blood glucose with exercise. The first panel is the most important panel, which is the blood glucose response during aerobic exercise. Insofar as you can always say always in medicine, blood sugar always falls with endurance exercise. This is because there's a mismatch between glucose use by skeletal muscle and reduced hepatic glucose output as a result of excessive subcutaneous insulin levels combined with reduced counter-regulatory hormone responses. The final panel is the other extreme. This is in brief, intense exercise. There is a counter-regulatory hormone response which produces a glucose response from the liver, but the counter-regulatory hormone response is in excess of the glucose requirement, so blood sugar rises. I'll come to this later on in this presentation because this is a useful technique for help stopping blood glucose from falling with exercise. The second panel is intermittent exercise, such as you might see in team sports. In this scenario, depending on the type of play, blood sugar may rise, remain largely stable, or fall. So for your team player, for example, who's running throughout the match, their blood sugar will behave more like the first panel, the aerobic response, with falling blood glucose, whereas for somebody doing short, intense plays, their blood sugar is likely to rise. These variations in glucose response need to be explained to your patient. The third panel is what happens to blood glucose with repeated resistance exercise, such as you might see with weight training in a gym. The first or second episode of weight training is likely to cause blood sugar to rise, but third or fourth episodes of weight training on the same day is likely to see blood sugar fall, and I'll expand on that later on in this talk. This slide shows typical responses of blood sugar during exercise. So we see in the top line blood sugar variations in people who aren't exercising. In the dotted line, we see aerobic exercise with a typical fall in blood glucose, followed by a post-exercise rise in blood glucose. In the third line, we see resistance exercise, where blood glucose falls to a lesser extent, but remains more stable afterwards. In this graph, we see different forms of exercise done in varying order. In the first phase, we see in the dashed line, aerobic exercise performed first, followed by resistance exercise. In this, blood sugar falls very rapidly, recovers during the resistance phase, but then continues to rise. In the case where resistance exercise is performed first, we see blood glucose remains stable, falls to a lesser extent during the second aerobic exercise, and then remains largely stable in the third phase. A simple piece of advice to give to your patients is if they're going to do mixed exercise, they may benefit from doing the resistance exercise first, then followed by the aerobic exercise afterwards. However, the effect continues into the evening. So we see that for those patients who've done aerobic exercise first, they have a tendency to have falling blood glucose in the early hours of the night. In contrast, the patients who've done the resistance exercise first, where blood sugar falls, if anything, towards the early hours of the morning. This is of use when patients are on insulin infusion pump therapy because we can advise that they might reduce the insulin infusion rate in the early parts of the night, but still maintain their insulin infusion rates at the later parts of the night to avoid early morning hypoglycemia. I'm now going to discuss the effect of intermittent high-intensity exercise. We've seen in the earlier graph that intermittent high-intensity exercise tends to protect against hypoglycemia whilst the exercise is being performed. However, there is a problem because intermittent high-intensity exercise is more likely to cause nocturnal hypoglycemia, as can be seen in this graph illustrated by the blue line. The rates of hypoglycemia are 3 times higher when compared with aerobic exercise in isolation. While people with diabetes may feel they are avoiding hypoglycemia with intermittent high-intensity exercise, such as you might see in team sports, they are in fact storing up potential risk of nocturnal hypoglycemia, and again, patients need to be warned of that risk. A short word about different forms of insulin therapy. We see in this panel that all 3 types of insulin, detamir, glargine and NPH, are associated with falls in blood glucose during exercise. However, there is a tendency for blood glucose to fall to a greater degree after the use of the longer-acting insulin analogue glargine, and this can be a clinical problem for patients doing aerobic and prolonged exercise. I sometimes have to change patients from long-acting insulin analogues to NPH insulin to avoid this problem. The patterns of blood sugar response that one sees with exercise can be summarised as in this slide. This panel describes the effect of exercise on blood glucose. Aerobic submaximal exercise causes blood glucose to fall rapidly. Intense exercise usually causes blood sugar to rise. Aerobic and submaximal exercise increases the risk of nocturnal hypoglycemia. Repeated resistance exercise will also cause blood sugar to fall. Intermittent high-intensity exercise protects against hypoglycemia during exercise, but is more likely to cause nocturnal hypoglycemia. And finally, team sports can have a variable effect on blood glucose depending on the position and intensity of play. I'm now going to move on to the risks of hypoglycemia. Hypoglycemia is common at night time in people who've performed exercise. The reasons for this are threefold. The first is whilst sleeping, people are less able to detect hypoglycemia. There is increased sensitivity to insulin as a result of exercise, as seen in this panel. In the upper panel, we see glucose infusion rates to maintain blood sugar during exercise and overnight, and we can see there's a second peak of increased glucose uptake between 1 a.m. and 3 a.m. So for the same amount of insulin, there'll be a greater fall in blood glucose while the person's sleeping following an episode of exercise. This is mediated through increased expression of a protein called GLUT4, which translocates glucose from the interstitial space through into the muscle. This increased expression occurs 12 hours after exercise and remains maintained for up to 48 hours after exercise. So for people who are doing intermittent exercise, they are more sensitive to insulin overnight on the day following exercise than on other days. This will guide us into the use of basal insulin therapy after those times. In addition to increased muscle sensitivity to glucose, there is a further factor. Episodes of hypoglycemia are likely to precipitate further episodes of hypoglycemia through reduced counter-regulatory hormone responses. And this effect is directly mirrored by the effect of exercise. Exercise acts like a surrogate episode of hypoglycemia and will increase the risk of hypoglycemia following exercise with reduced counter-regulatory hormone response. It's of interest that women are relatively protected from this effect. I'm moving now on to active management of this problem. The first mainstay of treatment is carbohydrate support. Why not just raise blood sugar to a very high level? Well, we've seen in the earlier graphs that raising blood sugar to over 20 millimoles per litre does not protect against hypoglycemia. And the reason for that is the available glucose in the blood and the interstitial fluid is very low. Only about 20% of the body's weight is accountable for this space. And for 1 millimole of glucose in a 70 kilogram person, that only equates to 2.5 grams of glucose. If you were to advise your patient to raise their blood sugar to 15 millimoles before an episode of exercise, that would only give 25 grams of glucose. For a 70 kilogram person working at a submaximal rate, that would only last approximately 12 minutes. It follows that we can't avoid hypoglycemia by methods involving raising blood glucose in isolation. We now move on to what can be done. In this panel we see teenagers who've exercised and had their blood glucose supported by giving carbohydrate in the form of glucose at either 65 or 55 grams given at small boluses throughout the exercise. And I think we can all agree that this has maintained blood glucose in a very satisfactory manner. We are recommending that people doing endurance exercise take between 0.3 and 1 gram of glucose per kilogram of body weight per hour of exercise, given in small bursts throughout the exercise. This is illustrated in this cartoon where we see strategy 2 is to take all the glucose at the start, which raises blood glucose and does avoid hypoglycemia, but is associated with a prolonged period of hyperglycemia. Far better to give small amounts of glucose throughout the period of exercise to reduce the fluctuation in blood glucose. This can be advised to patients to give their glucose every 10 to 20 minutes, between 10 and 20 grams of glucose throughout the exercise to maintain their blood sugar. Clearly, if their blood sugar is rising at the end of this period of exercise, they should reduce their glucose intake, and the corollary of that is if their blood sugar falls, they need to increase their glucose. This is a template they can work to adapt their glucose ingestion to maintain their blood sugar at a normal value. The next important strategy is insulin dose adjustment. In this nice study, we see repeated episodes of exercise in the same individuals who've either reduced their lisoproinsulin in the bolus dose before exercise by either 25, 50 or 75% prior to exercise periods of between 30 and 60 minutes at various rates of intensity. The patterns of response are very similar in each of these panels. All are associated with pre-exercise hyperglycemia, and it's this pre-exercise hyperglycemia which limits the use of this technique to between 90 minutes and 2 hours after the bolus shot of insulin. But in each occasion, the fall in blood glucose during exercise is reduced by a reduction in the bolus dose of insulin. This graph shows the suggested bolus dose reductions to be performed before an anticipated form of exercise, and I think it's quite surprising how big the bolus dose reduction should be. When you're advising your patients how much they should reduce their meal-related insulin dose down before an episode of exercise, I think a reasonable starting point would be a 50% reduction, and it may well be as they become fitter and do more physical exercise that the dose should be reduced still further. I'm now coming to the issue of the basal dose. Reducing the basal dose of insulin before a period of exercise will reduce hypoglycemia whilst you're performing the exercise, but is associated with persistent hyperglycemia for the rest of the day. However, as we've seen earlier, because the increased sensitivity to insulin following an episode of exercise, we can safely reduce the basal dose of insulin following a period of exercise, and we're suggesting a 20% reduction in the basal dose of insulin on the night following exercise. In this study here, we see how subjects have been asked to reduce their basal insulin dose by 20% in the red line or keep the dose the same on the black line. And we can see where the insulin doses remain the same after a period of exercise, blood glucose falls, but in those subjects who've reduced their basal dose by 20%, they maintain quite steady blood glucose overnight. And this really is a mainstay of advice for people doing irregular exercise less frequently than alternate daily. They should reduce their basal insulin rate down by at least 10% and probably 20% to avoid nocturnal hypoglycemia. So in summary, the insulin advice that's possible, we can reduce the prandial insulin dose if the exercise is going to occur within 90 minutes of the insulin dose by approximately 50% to avoid hypoglycemia during exercise. And we should also be reducing the basal insulin dose by 20% on the night following a period of exercise if the exercise is intermittent, less frequently than alternate daily. My colleague Peter Adolfsson has kindly agreed to let me use this slide to illustrate the summaries of strategies with exercise on multiple daily insulin regime. After a normal meal between 3 hours and 2 hours before the exercise, the normal bolus dose of insulin is given. However, if the episode of exercise was closer to the meal, we would be advising reducing the bolus dose by 50%. If blood glucose is less than 6 millimoles before the exercise, we're suggesting a 10-gram glucose snack. Glucose is replaced during the exercise at the rate of 0.3 to 1 gram of glucose per kilogram per hour of exercise. And there's a post-exercise glucose replacement if hypoglycemia has occurred. A meal occurs 1 hour after the exercise with a reduced bolus dose, and we're suggesting half the normal insulin to carbohydrate ratio. I'm now moving on to insulin infusion pump therapy. The prospect of insulin infusion pump therapy looks very attractive in the concept of exercise because it enables low levels of insulin to be achieved during exercise, which approximates the physiological state. It also enables a rapid post-exercise increase in insulin dose to maintain post-exercise euglycemia, and I will show you a panel to confirm that later on in this presentation. It will enable a temporary lower basal rate to be infused on the nights following exercise, and to my view, this is the gold standard for people who are planning to do regular physical exercise. This is some data from our lab which shows our attempts to quantify how much insulin dose reduction should be made during exercise. In the first panel, we see When we've reduced insulin infusion rate to 50% normal, hypoglycemia occurred in nearly 85% of people doing the exercise. When we reduced the exercise-associated insulin infusion rate down to 20% normal basal rate, we substantially reduced the risk of hypoglycemia, but as you can see in the red panel, the risk of hyperglycemia exercise was increased. So for this particular form of exercise, the insulin dose reduction would have been somewhere between 50% and 20% to get the best of both reduction in hypoglycemia and avoid post-exercise hyperglycemia. This study shows the effect of insulin infusion pump therapy on the patient's ability to control their blood sugar after exercise. And I think we can agree that the pump-treated patients who are the lighter line have a better degree of glucose control after exercise than the patients on multiple daily regime on the black line above. This follows a similar pattern to the previous cartoon. Similarly, there's a pre-exercise meal, and again, if the meal was within 90 minutes of the exercise, we would be advising a marked reduction in the bolus infusion rate. A carbohydrate snack if hypoglycemia is present before exercise. Carbohydrate is ingested whilst the exercise is being performed, with a post-exercise glucose ingestion if hypoglycemia has occurred. A meal 1 hour after the exercise, with a reduced bolus dose. However, the variation is that we're able to reduce the insulin infusion rate. A temporary reduction in the basal infusion rate between 1.5 to 2 hours prior to exercise is suggested, and then back to the normal basal rate when exercise is finished, with the aim of keeping the blood sugar in the range of 5 to 8 millimoles and avoiding the risk of hypoglycemia. There are some novel strategies that also help. I've shown you the blood glucose response to severe exercise earlier on in this presentation, and this can be used effectively in the form of the maximum sprint. A brief, intense period of exercise at approximately 10 seconds will produce a counter-regulatory hormone response which will protect against falling blood sugar after exercise. This can also be used before exercise. It's this mechanism that stops blood sugar falling during intermittent high-intensity exercise. In a similar manner, it's hypothesized that caffeine, which augments the sympathoadrenal response to exercise, might be useful in avoiding hypoglycemia. In our lab, we tried this at the rate of 3 times the daily average caffeine ingestion taken an hour before exercise. And whilst this was successful in avoiding hypoglycemia, it was relatively poorly tolerated. We repeated the exercise at a lower rate of caffeine ingestion, but unfortunately the lower rate of caffeine ingestion did not protect against hypoglycemia. Mike Riddell has performed this experiment in insulin infusion pump therapy with similar responses. However, I don't think we can routinely recommend caffeine ingestion at this dose before exercise to avoid hypoglycemia, but modest caffeine ingestion in conjunction with insulin dose adjustment and carbohydrate ingestion may be useful in combination to avoid hypoglycemia. I'm going to summarise the possible clinical strategies with the benefits and disadvantages of each strategy. Reducing pre-exercise bolus insulin reduces the risk of hypoglycemia during exercise and reduces the need for carbohydrate replacement, but it does require pre-planning. It's not helpful for spontaneous exercise, as you might see in boys and girls, and it's not helpful for late postprandial exercise. Reducing pre-exercise basal insulin will also avoid hypoglycemia during exercise, but it can cause pre- and late post-exercise hyperglycemia, and it is difficult to use and requires some degree of sophistication. Taking extra carbohydrate remains the mainstay of support of blood glucose during exercise. It's useful for unplanned or prolonged exercise, but it may not be possible in some forms of exercise. It's not helpful where weight control is important, and it's easy to over-replace, causing hyperglycemia. The pre- and post-exercise sprint reduces hypoglycemia following exercise, but unfortunately the exercise is somewhat limited. Insulin infusion pump therapy, as I've previously stated, offers flexibility and rapid change in insulin infusion rates post-exercise. It is expensive, and it may not be practical for some contact sports such as rugby or football or judo. Finally, in virtually every circumstance, basal insulin reduction should be reduced following exercise, but can cause morning hypoglycemia. I hope that this presentation will be useful to you and you'll be able to take some of these clinical scenarios back to your services so that you can advise your patients with type 1 diabetes more effectively, so that they can enjoy their physical exercise more safely and with better degree of glycemic control.
Ian, we hear a lot about low carbohydrate diets as a way to control excessive glycemic excursions. Is this an approach that works in the exercising patient with type 1 diabetes?
Helen, a lot of patients have come to ask me about that. The very low calorie diets are probably not safe in type 1 diabetes, but the moderate calorie reduced diets probably are useful, provided that the insulin dose is reduced in an appropriate manner and that the basal dose is also reduced. However, it's likely that these low carbohydrate diets will impact on maximum physical performance seen in sprint exercise.
Do you think real-time CGM is of use for endurance type activities?
Yes, it's very useful, but unfortunately, because subcutaneous glucose lags behind arterial blood glucose, the interstitial glucose level lags some way behind arterial blood glucose, and that effect is somewhat unpredictable in rapidly changing blood glucose as we see in exercise. So the direction of travel is largely predictive of what's going to happen to blood glucose, but the absolute value that the CGMS monitor records is somewhat inaccurate. So if a person's on CGMS monitoring and they have 2 arrows down on their monitor and their blood sugar is 5, then they should expect that their hypoglycemia is very close to occurring.
Are there any other techniques that can be used to control blood sugar during exercise except for taking extra carbohydrate?
Yes, there are. Taking extra carbohydrate does work, but for the people who are trying to control their weight, the extra glucose ingestion is somewhat counterproductive for weight control. And there may be scenarios where people don't want to take extra carbohydrate. We've found that the maximum 10-second sprint performed either before exercise or following exercise is very useful at maintaining blood glucose for short periods during endurance exercise. There's some limited experimental data which might suggest that caffeine ingestion may support blood glucose as well. I don't think we're at a stage where we can recommend this, but I think the combination of a small amount of caffeine combined with a maximum sprint is likely to show that blood glucose can be supported more effectively during endurance exercise.
Ian, with your experience with high-level athletes, is there an adverse effect of high glucose levels on performance? And if so, in your experience, what is the ideal blood glucose?
There is both clinical and experimental evidence to show that high levels of glucose before exercise in elite athletes does reduce performance. So very high levels of glucose is associated with reduced muscle strength and easy fatigability and an increased tendency towards cramp. But I would not advise higher levels of sugar than that to do intense exercise. Where blood sugar is above 12, I think people should do low intensity exercise to bring their blood sugar down before they return to their more normal work output.
A clinical challenge for most of us is to give advice to patients who have been inactive and want to increase physical activity. Are there any key messages you give in this situation?
Yes, the key message is to encourage people to do that at all ages. And I think clinicians and healthcare professionals should encourage all ages to do more physical activity. Safety is very important, so we need to warn about the risk of hypoglycemia, and we need to ensure they're not at a risk of foot ulceration if they have neuropathy, if they have long-standing diabetes. The next key message is that there's likely to be a variation in blood sugar response both at the start and as exercise increases, and to explain to the patients what their strategies are to correct their variation in blood glucose. I think that it's very important they do understand as they become fitter, their need to reduce insulin levels and increase glucose replacement will increase, and they may find that their insulin doses drop down quite a long way, particularly their overnight basal insulin dose. I'd also warn of the increased likelihood of nocturnal hypoglycemia and where possible advise other family members how to treat that.
You've managed people who engage in what most of us would call extreme activities. Which has presented the greatest challenge?
I think the ultra long endurance exercise like the Ironman triathlon or transatlantic rowing or the very prolonged cycle races which last many days with little sleep have presented the biggest problem. For each of these is required working out what the appropriate ambient insulin levels should be during the exercise, associated with how do we give insulin to support normal blood sugar responses after eating food, and decide how best to manage meal replacements with bolus doses so that the risk of hypoglycemia is also avoided. And with careful thinking and planning and the ability to change track if the response is not satisfactory, that these events can be managed.
Ian, some guidelines prohibit exercise if a blood glucose is above a certain level. Do you think that this has a valid basis, and what advice do you give?
So those guidelines are based on the concern that short intense exercise may raise blood glucose and turn unstable diabetes control into diabetic ketoacidosis, either by measuring their blood ketones, and their blood ketones are greater than 2 millimoles and probably greater than 1 millimole. They should manage their hypoglycemia with insulin shots to bring their blood glucose and their ketones down. However, if they're hypoglycemic and they have low levels of ketones, then another strategy will be just to do low intensity exercise so the blood sugar falls. So I think the advice is sensible, but there is a nuance depending on whether there's a likelihood of ketoacidosis.
Do you think that fitness level has an influence in the propensity to hyperglycemia?
The level of fitness is very important for people who are returning to exercise who are physically unfit. Because they're not doing much work and there's a large counter-regulatory hormone response, they often notice their blood sugar rises in the first few bursts of training. As the training improves and the work output increases, the tendency then is towards blood sugar falling with exercise, as you'd expect with any endurance exercise. So if you've got somebody returning to exercise for the first time after many years, you do need to warn them that they don't need to over-replace with carbohydrate at the start. However, as they become fitter, the work output increases and the glucose use also increases, so they return to the more normal pattern of falling blood glucose during endurance exercise. I think when you're advising people returning to physical activity that they will see both these changes. They should be increasing their carbohydrate intake and reducing their insulin doses as their physical work improves.
In Australia, we have a number of adolescents who engage in competitive swimming, and this presents difficulties on competition days, especially in pump-treated patients. Do you recommend using injections only in this situation?
Well, many pumps are water resistant or even waterproof, so if the swimmers are willing to continue wearing the pumps, then they can do so. But for those people who do not want to continue wearing their pumps, want to take their pump off, if the pump is going to be removed for more than about 2 hours, they will need to give themselves a tethering dose of insulin. That can be done in a couple of different ways. It can either be given as a bolus dose of short-acting insulin immediately before the event, once the pump has been taken off, or as a basal dose in the morning if the pump is off for a longer period of time. But this tethering of insulin is important if the pump is going to stay off, because the late post-exercise hyperglycemia, when the pump has been removed, can be really quite problematical.